Thank you, Patrick. Hello, everybody. I want to thank Dr. Al-Sheikh for asking me to do this lecture. Between researching for this lecture and listening to TV, I'm having coronavirus overload syndrome. But I am going to do my best in the next 30 minutes to bring you up to date on what I've learned about corona and cardiovascular disease. This is an overlook at my talk. I am going to talk a little bit about what exactly the nomenclature is, so we're all on the same page. I'm briefly going to review previous pandemics. I know you've read and heard a lot about them. I just feel like I need to set the stage. And probably the most scientific thing that I'm going to attempt to convey to you is to talk about the viral binding and entry and mechanism of injury. I'm not a virologist, I'm a clinician, but I've spent a lot of time researching this, mainly because I think it's very important for the cardiologist to understand this, because this is going to be the target of treatment. I do want you to know that I got all my information from the American College of Cardiology. I also happen to have a cousin who's a head of the School of Public Health and Environmental Medicine who is really an expert on this. And he spoke with me directly and helped me on some of my slides. The focus of my talk is what we know about COVID-19 and the cardiovascular system. Keep in mind, everybody, that the data that's coming out in this disease is coming out so fast, I could barely keep up with it. Every day, in fact, this morning, they just printed a new cardiology article for the interventionalist. They did one for palliative care. I've read every one of them, and I'm going to try to summarize them. But remember, they're not peer-reviewed. They're printing everything that can come out. Not all of this. This is as factual as I can make it. I'm going to talk about the comorbidities, the presentation, and we've heard that there are cases of myocarditis. I'm going to conclude by talking about the sites of treatment and myths and fallacies, and then my final concluding slide. So just to make sure we're all talking about the same thing, we know that the virus is named the SARS-CoV-2. SARS-CoV-1 was back in 2002. The disease is called COVID-19. It stands for Corona Virus Disease 2019. Why is it called Corona? Because this is a picture of the viral specimen. It kind of looks like a sunburst, and it's called Corona, although 30% of Americans think it was named after the beer, apparently. I don't think I need to go over this, but we know that coronavirus is a large family of viruses that have been around for a while. They're alpha and beta viruses that most of them cause the common cold. They're mild, we get over them. However, in the last 20 years, we've had 3 cases of a zoonotic origin virus that has been quite severe. And I'm going to briefly talk about the previous SARS virus, MERS, and now the COVID-2. Sorry, went the wrong way. So we all know it's a global pandemic. As of the Johns Hopkins site of engineering and statistics, I can't keep up with this. I think the deaths are now like 104,000. As of April 13th, 20,000. Now I think it's 23 in the US. The number of cases outside of China exceeded China March 15th. This is a single-stranded, oh, you know what this is? This is a viral particle of RNA that is wrapped in an envelope, a lipid envelope, and it's invading our cells. And I'm going to tell you why it hits predominantly the lungs, but it also, 20% of autopsies show that it's in the heart. The autopsies are not from this pandemic, but from the SARS pandemic. It's very similar to SARS and MERS in that it's a zoonotic. It started in bats, and they had an intermediary. In SARS, the intermediary was like a clivet. It's like a cat-like animal. In MERS, it was the camel. I was kidding Dr. Al-Sheikh about that. And they don't know what the intermediary is in the current virus. So, real briefly, for those of you that don't know, in 1918, the world was at war, and the United States was included, and there was the Spanish flu. It had nothing to do with Spain. The facts are, It started in Kansas in the United States, and the facts are that we shipped soldiers with the virus over there. The reason it's called Spanish flu is because at that time, the media was being blocked out and they didn't report it. But Spain was not involved in the war and they reported the virus, and it became known as Spanish flu. What I want you to know about this first pandemic, it probably was the H1N1 virus. It killed it affected, I'm sorry, 1/3 of the planet's population, killed 20 to 50 million people. The SARS virus came about in 2002, 2003. The SARS virus epidemiologically is extremely similar to what we're dealing with now. It started in the Guangdong province of China, and it also had a bat reservoir, and it was very similar to this, except where you're going to hear me talk about the CFR, that's the case fatality rate. It was higher, 10%. Case fatality rate is the number of deaths over the number of people infected. I think everybody's heard that with the current virus, we don't really know how many people are infected. So that number varies from country to country, and it's not clearly defined. Then in 2012-13, we had the Middle Eastern respiratory syndrome, and it was quite severe. It had a mortality rate of 38%. As Dr. Al-Sheikh just said, it was a very short period of time. But these three pandemics are very similar in that this is more in the MERS. The primary reservoir bats, intermediary camels, very similar, but a much higher fatality rate. And so, again, this virus is known as SARS-CoV-2. The disease is called COVID-19, just to be clear. We know that it originated in bats because the virus shares 96 to 99% of the nucleotides. It started in a wet market in Wuhan. If you know what a wet market is, it's called that because they serve all kinds of animals, including fish, live and dead fish. They believe the intermediary is an animal called a pangolin, but it looks kind of like an anteater. And these are just some pictures. I'm sorry to share this with you, but I had to share some pictures of what this wet market looks like. They have dogs and cats in cages right next to other animals and snakes and bats, and it's not very sterile. Let's just leave it at that. And you can pretty much get anything there. So that, by the way, as of yesterday or 2 days ago, according to the Wall Street Journal, that market, those wet markets are back open in China. So just to tell you that these three pandemics, not including Spanish flu, which was H1N1, but I guess we could include it, all began as zoonotic. That is that these viruses live in birds, bats, then they infect an intermediary host. I'm gonna give you some conjecture of why they don't affect those animals, but they're transmitted to man and woman, and they cause quite severe respiratory symptoms with high fatality rates. And so we're going to talk about, if you look on the right of this slide, right here, we're going to talk about the attachment receptor. I don't want to confuse the listener, but this is very important. I spent a lot of time reading this, and I think we as doctors and healthcare providers need to understand this, to understand how this works. And I'm telling you, this is going to be the targeted treatment. And this is what's going to be the cure, and it's going to help other diseases, other respiratory diseases. So let me go right in to the ACE2. Now, I think a lot of our listeners know what the angiotensin converting enzyme is and ACE1. ACE2 is a receptor that binds the virus through an S spike. Give me a moment. The next slide is going to show you a picture. These ACE2 receptors, the ACE2 is homologous to angiotensin converting enzyme. That means it looks just like it, but it binds to this. I don't remember learning this in medical school, but my son's taking immunology right now, and they are learning this. It provides a negative feedback to stop the production of angiotensin 1. Keep with me, I'm going to go over it. ACE2 receptors are found predominantly in the lungs. They're produced by the Clara cells. but they're also in the intestines. That's why these patients get diarrhea. They're in the vascular endothelium, they're in the kidneys, they get kidney failure, and they're in the heart. There are 20% of autopsies showed them to be in the heart, and that's why they can get a myocarditis. This ACE2 receptor is the way that angiotensin is broken down. So let's look at this. The coronavirus, that's it in the big orange with the S spikes. These S spikes are proteins that are sticking up, and that is where it enters the cell. It enters through this ACE2 receptor. So it is entering the cell through the same receptor that the blood pressure medicines we use block. The same receptor that angiotensin, ACE inhibitors, you've heard of that, angiotensin converting enzyme, angiotensin receptor blockers bind to this receptor too. And that's caused quite a bit of debate. And my cousin's directly involved in that debate. He was quoted in Newsweek, and I'm going to tell you about it. But they bind to this receptor, which is a portal of entry. And this receptor undergoes a transformation and allows the virus, the RNA, to enter the cell where it replicates. There is a protease right here that's known as the furin protease that cleaves this receptor that allows it to enter. This is interesting. This is more than I should know as a clinician, but that protease is not found in bats. And that's why this virus doesn't hurt the bat, doesn't cause lung damage, but it is found in humans. I'm going to tell you that this receptor is going to be the site of a lot of the medical research in antibodies. So this is a diagram all medical students had to learn, but I don't remember this part of it because I'm so old, but this is new and they're talking about it. We all know that angiotensinogen is produced in the liver. The kidneys, the juxtaglomerular apparatus, releases renin, and it produces angiotensin 1, a decapeptide. ACE converts this to angiotensin 2, an octapeptide that is a vasoconstrictor. It also causes cell proliferation, and this binds to AT1 and AT2 receptors. And this is where the injury occurs. This is where the injury occurs. It's causing vasoconstriction and tissue hypoxia. Now, what normal people have is they have this ACE2 receptor that breaks angiotensin down to angiotensin 1 to 7. This is just the opposite. It's a vasodilator, and it inhibits cytokines, and it is helpful. The problem is when the virus binds to this ACE2, it inhibits this breakdown process. So what you have, without getting too complicated, is you have unregulated angiotensin 2 production. That's what they're finding. There's lots of articles on this. For the cardiologists that are listening, there are direct articles at your ACC website about this mechanism. So here's what's interesting. Animal studies show that when they infuse ACE inhibitors into an animal, they upregulate the number of these ACE2 receptors. So there was a conjecture about a week ago that people on ACE inhibitors and ARBs may be at higher risk. In fact, they thought that's why they were seeing so many people with heart disease develop bad COVID-2. However, that's not been proven to be the case. In fact, they're now thinking that ACE inhibitors and ARBs may mitigate the risk of SARS-CoV-2 because it blocks that receptor. So there are now treatments. They're actually doing trials with losartan to see if it can mitigate the degree of lung injury. All societies, the American Heart Association, the American College of European Cardiologists, ACC recommend against stopping ACE or ARBs or any renin-aldosterone angiotensin antagonist. That's the only science, guys, I'm going to go into, but you need to understand this so I can talk about it a little bit later. And I'm sure there'll be some questions on this at the end. So now let's go into the meat of the talk, which is not that much data, but I'm going to talk about the cardiovascular disease. We know that COVID-19 interacts with the cardiovascular system on multiple levels. I just tried to tell you why that is. And more than 7%, or I guess a number that means more to me, 22% of the people in China that were critically ill suffered by definition a myocardial infarction by cardiac biomarkers. This is the word case fatality rate, and you can see it really different around the world. Germany seemed to have the lowest case fatality rate, possibly because they developed a test kit pretty early. The USA numbers are fluctuating. It all depends on the denominator. But the reason I put up this slide is what I want you to know is what you already do know, is that it's much higher risk as people get older. As people get older, it's as high as 14% in octogenarians. That's why we're trying to socially distance ourselves from our elders. So we know that the presence of diabetes and cardiovascular disease increase the risk of death 12-fold. This is similar to SARS and MERS. And we know that a lot of the people in Wuhan that were intubated or in ICU, over 50% had these comorbidities. 35% had hypertension and 17% had coronary disease. Why? We don't really know. It may be simply that cardiovascular disease is more prevalent in those with advanced age. It may be that more advanced age leads to a functional impairment in the immune system. It may be that people that are on ACE inhibitors, ARBs, have elevated levels of ACE2 receptors, which is the portal of entry of the virus. It may be that there's just people that have comorbidities are predisposed. We don't know really right now. Obesity, I heard today, is also turning out to be a major comorbidity. So in China, the data did show that 10.5% of the people that died had heart disease, with diabetes being second, respiratory disease, high blood pressure, and cancer. So it's our population of patients that we need that are being targeted as high risk. Now, I told you myocardial injury was very prevalent, as indicated by cardiac biomarkers. In China, 22% of the patients in the ICU had abnormal echoes or abnormal EKG or cardiac injury. 12% had no known coronary disease, but had presented with elevated troponin or cardiac arrest. These are not small numbers. High sensitivity troponin was above the 99th percentile upper reference in 46% of the people that did not survive. In other words, it was a marker of death, as opposed to 1% of the survivors. So according to the ACC website, there's only anecdotal reports, but Dr. Al-Sheikh did ask me to talk about this, and this is directly applicable to what we do. There's two patterns of myocardial injury that are recognized. One presents right off the bat with chest pain and acute myocardial symptoms, including fulminant myocarditis. One presents with a delayed injury pattern. This is sort of the pattern. You can see in non-survivors, at least most of these did not survive. In day one, their troponin was elevated and it ramped up very severely. We know the lifespan in the unit was usually around 20 to 21 days. You can see it went up to 290. Their D-dimer levels were elevated, their interleukin-6, all the acute phase reactants, ferritin, LDH was high. The survivors who had elevated troponin presented, and it was sort of that mild elevation in troponin that remained stable with no change. It's now recognized that these patients probably have a viral myocarditis, and it's probably due to a cytokine storm. If you haven't heard this word before, this is a word that's kind of being associated with ARDS syndrome, certain types of cancer, CAR T syndrome. We have anecdotal reports out of China that are discussed at the ACC website. I'm going to present one of them. There was only two. This is anecdotal. This is two cases where they did treatment. That's the best that we have. A 37-year-old male is admitted on January 14th with chest pain and dyspnea for 3 days, accompanied by diarrhea. He was in shock with a blood pressure of 80/50. The chest x-ray shows enlargement of the cardiac silhouette. The CTA shows a typical posterior box-like infiltrates at the bases of the lungs, but his EKG showed ST elevation in the inferior leads with myocardial infarction. They did a cath on him, which showed normal coronaries. Troponin T was over 10,000. MB was only mildly elevated. Pro-BNP 21,000. Echo, dilated heart with an EF of 27%. I've seen 3 cases now discussed in the literature where the doctors chose to give steroids. As you're aware, and I'm going to mention it, steroids are not recommended in the typical patient with this disease. It will make them worse. But they gave them methylprednisolone at 200 milligrams per day for 4 days. They gave IV immunoglobulin to regulate the immune system, 20 grams a day for 4 days. They had to treat the hypotension with Nurepi, milrinone to increase cardiac contractility, and they gave antibiotics. Within 1 week, the heart had returned to normal size, EF had normalized, troponin was dropping rapidly, as was the BNP. This patient had a full recovery. There was a second case that was very similar to this. So what I want the listener to know, studies in general show high-dose steroids are not beneficial. The WHO, World Health Organization, CDC, do not recommend this unless you have a case of fulminant myocarditis. As I said, the clinical picture is akin to a cytokine storm, which I had to learn about CAR T cell therapy. Sure, our oncologists know all about it. Actually, my neighbor is Dr. Sonnenberg and talked to him about it. It leads to uncontrolled angiotensin II. I'm hoping now you, as a listener, I showed you the slides, understand how that can happen because of that receptor. Interleukin 6, excessive calcium leads to apoptosis. And they're also looking at interleukin 6 antagonists as a treatment. It should be, I already mentioned it, but in the Toronto SARS outbreak, they found the SARS virus in 35% of autopsied hearts. So it directly, in 1/3, is affecting the heart muscle. The American College of Cardiology issued a statement, a paper about heart and renal transplant patients, whether they should be continuing to do them at this time. 2 case studies from the Hubei province of China, both presented similar to non-immunosuppressed individuals. Fever, CTA was the same, laboratory data the same. They were given antibiotics, antiviral treatment. One got immunoglobulin and methylprednisolone, like we talked about, and they survived. The current recommendations for those places that are doing heart renal transplants is to continue, but quarantine any donor with known or suspected COVID-19. All right, what are the treatments that are being talked about? I think you're going to understand this a little better since I went over the mechanism of entry. They're looking at monoclonal antibodies to target the cell invasion and the replication, and that is directly related to that ACE2 receptor. To be honest with you, I listened to a virology lecture from my son's medical school, and the recombinant human ACE2 antibody was developed in 2010. This was all developed in mice models, and to be honest, it's been dormant. They're trying to bring it back rapidly to restudy it. We don't have an animal model right now. Remdesivir was a drug that was developed to fight Ebola. It is a broad-spectrum antiviral that interrupts RNA replication. Clinical trials are going on with remdesivir in China and the USA. Dr. Verma talked about chloroquine and hydroxychloroquine, and that are used normally to treat malaria or rheumatoid arthritis and lupus. They block the SARS-CoV entry into the cell. Studies have suggested a decreased length of hospitalization and earlier viral clearance. These drugs are being studied. Obviously, I am hearing about risk, and I'm going to show you a slide on some things to do with these 2 medications. I think hospitals are right now, including ours, they just had a medical exec meeting yesterday to talk about who should get these drugs. Because to be honest, even in our own hospital, there's difference of opinion among the infectious disease doctors and among the intensivists. There's drugs that are used to treat HIV called lopinavir and ritonavir. These are protease inhibitors. They're looking at these, but the early trials have not been as impressive as they thought. The other drugs that our oncologists are used to are monoclonal antibodies against interleukin 6. I mentioned them. They use them against this cytokine release syndrome. I think these are going to show promise. Trials are going on in the US and China. Antimalarials, I just covered it. antiviral effects. This is just some curves showing you in the black line, that's controls, and blue is hydroxychloroquine alone, and green is hydroxychloroquine and azithromycin. And if you look, the y-axis is the polymerase chain positive samples, and you can see that it really decreases viral replication by day 5. Pretty impressive curves. This is a sad case you may have heard about. A couple in Phoenix, Arizona, took a form of chloroquine that's meant for fish tanks, and they took it, and the husband died of a cardiac arrest, and the woman was admitted in critical care. Needless to say, we've really got to educate the public and the doctors and use these medications very judiciously. All right, what are areas of hot research? I hate to keep talking about it, but the ACE2 receptor is a therapeutic target. I'm reiterating, I'm repeating myself. It degrades angiotensin 2 and it forms angiotensin 1 to 7, which is just the opposite. It is anti-proliferative vasodilator, antithrombotic. So we need that, and the virus inhibits that. They're looking at a monoclonal antibody. The axis is a promising target. I really think, after reading about this and preparing for this lecture, this is going to change some of our therapy for really sick people besides the COVID-2 virus. Some of the myths and fallacies, as of initially, they told patients not to take ibuprofen. As of March 19th, the World Health Organization reversed its recommendation due to lack of scientific evidence. They thought that ibuprofen is a COX-2 pathway inhibitor, and it may increase the ACE2 receptors in animal. It does increase the ACE2 receptors. Anyway, I would tell patients myself to take something else if they could, but they did reverse their stand. Pets, even though this is a zoonotic virus, as of this time, we don't know the exact animal that's an intermediary host, and we don't have any evidence that companion pets like dogs and cats can spread the COVID-19. So I just thought that was important to get out there. You know, we know that young people can get the virus and they get better. One sign of that, there is ACE2 receptors in the nose and mouth. That's why they swab your nose. And the young survivors of this tend to lose their sense of taste and smell. And that's because of the expression of ACE2 receptors in the oral cavity and nasopharynx. So if you hear any patients say that could be a clue. So in conclusion, cardiovascular comorbidities. Before I do the concluding slide, let me just say that I didn't have time to make a slide, but there was a paper printed today at the ACC website. It's a consensus document that guides triage for structural heart disease during COVID-19 pandemic. And it's released by the ACC and the Society for Cardiovascular Angiography. I read it, and it really is pretty intuitive. I mean, to try, it just came up with some guidance of who to do TAVR on and mitral valve repair and who to do interventions on. So our interventional colleagues may want to look at that. In conclusion, cardiovascular comorbidities are common in these patients. In such patients are at high risk. It is not known if the presence of cardiovascular comorbid conditions is an independent risk factor or it's mediated by other factors. Myocardial injury is present in 1/4 of critical care patients and patients intubated, and it presents with 2 patterns, a fulminant myocarditis or a slow injury that tend to do much better. Continuation of ACE inhibitors and ARBs is recommended based on available evidence. I'm reiterating that because 2 weeks ago, they actually had a report out of Lancet, and my cousin wrote in Travel Medicine that perhaps we should stop these medications. They're not recommending that. A number of promising treatments against the ACE2 receptor and viral entry and replication are underway. And I think we're going to stop this virus, and we're going to learn a lot. And Patrick, I'm ready to open up the mics for anybody to provide more education or ask questions.
Beautiful. Thank you so much, Dr. Videau. We all really appreciate it. Before I unmute everyone's mic, I would think it'd be really nice if you guys could join me in giving Dr. Videau a quick round of applause for giving us such an awesome webinar. I didn't see any.
It sounds like somebody being killed on the mic.
I was wondering what that would sound like. So if we could potentially now open it up for questions. I ask if you're not talking to still stay muted so we can hear everyone. I'll just go ahead and mute y'all real quick. I made it so you guys can unmute yourself if you do have a question, but so we can hear everyone. Just wanted to open the floor to questions. Please let us know if you have any. And like I said, you'll have to unmute your microphone to ask it. You should be able to, or type it in the chat if that's easier.
Hey, Dr. Videau, this is Teresa Yates.
I need to unmute.
I unmuted him. He was muted.
Okay.
Can you mute him back? No, I'm just kidding. No, I sent a little chat. We do have those guidelines, and we do screen all of our structural heart patients. Currently, the staff is calling them the more frail ones weekly, and the ones that seem to be more stable every 2 weeks, and the ones that are more frail that are being admitted with CHF, the ones having syncope or have critical aortic stenosis. Those ones we're moving forward with and doing the cases. The rest are being put on the back burner.
And Teresa, that's exactly what they recommended, was weekly phone calls to the patients that are more frail. So
hey, like I tell the patients all the time, I'm not as dumb as I look.
Very good. Excellent job. Other comments? I'm anxious to hear any experiences out there that anybody can share with the group.
I'm seeing some things in the chat that people have typed in recently. Pardon me if I say anything incorrect, but Randy said, I'm seeing some info regarding a hypercoagulable state and anticoagulation. I saw a paper about it yesterday. Have you seen any current info about this?
You know, Randy, I did not see anything about anticoagulation. I'm opening up the mic for anybody that's read that. That's very important if that's true.
Dr. Videau, this is Thabit. Any parameters or anything we can follow once we have evidence of cardiac involvement that will favor good prognosis or otherwise? Once we have evidence of cardiac involvement by cardiac enzymes or echo with decreased left ventricle function, any data?
Yeah, all I have, Tabit, is those case reviews, and they obviously were following. I don't know if we're capable of measuring interleukin levels in our lab. I would suspect not, but they're measuring those acute phase reactants, and I think if they're not decreasing rapidly, that's a bad sign. And by the way, there was a big article yesterday at the ACC website about getting palliative care involved early on this group of patients, for what it's worth. But all I know about is that slide that I presented to you, the markers, and it looked to me like the echo showed improvement pretty rapidly.
We had one patient in the unit that I was consulted on. She came in and she's still on the ventilator as of last week. And the initial echo shows ejection fraction around 40% or slightly lower. And actually, a few days later, ejection fraction was in the 60s. And I don't know, like you said, it's like almost a stunned myocardium, but that's the only patient I have experience with. That's why I was wondering if the clinical course, you know, if we have any more data regarding clinical course, once there's evidence of cardiac involvement, that may be different than the usual myocarditis.
Right. Honestly, I've been looking every day, and what I presented to you guys is what is available at the website.
That's an amazing job. Thank you so much.
Okay, I really enjoyed it. I thank all of you for tuning in, and I'm hoping to go back to work here in 2 days, and I'm hoping you guys get to enjoy the quarantine period.
Thank you.
Thank you, Pat.
Thank you, Dr. Videau.
All right, thank you all.
Thank you.